Hi, everybody. Thank you for joining us today for MVC's Rural Health Workgroup presentation. My name is Rachel, and I'm one of the site engagement coordinators with MVC, and I'm happy to help facilitate the workgroup today. This is our agenda. We're going to go over some housekeeping and P4P reminders. Then we'll have our presentation by Lindsey Crouch at Hillsdale Hospital. And then following the presentation, we'll have a discussion, Q&A time, and then we'll go over some of our MVC updates and upcoming events. So some of our housekeeping items, just a reminder that this session is being recorded. The slides and the recording will be shared with attendees via email following the work group. We usually send this out later in the afternoon to give us some time to pull everything together for you guys. A reminder also to please mute your microphone to help reduce the background noise during the presentation. You're welcome to unmute if you have any questions during the discussion portion, though. And then if you think of questions throughout the presentation, you're welcome to put them in the chat and we will read through those at the end during the discussion part. For our P4P participating sites, we do ask that you have active participation during the work group. That means answering any discussion questions or asking questions of your own, and then also participating, and engaging in the discussion during the question time. And then at the end of the work group, we'll be sharing a link for the post work group survey. This actually is for everyone, not just P4P sites. But to get your P4P engagement credit, you do need to fill the survey out for your site. And Emily will put that in the chat at the end of the work group. We will also be sending that out in the email as well. Okay, so for today's presentation, we are welcoming Lindsey Crouch from Hillsdale Hospital. Lindsey is the Director of Outpatient Clinics, Home Care, and DME at Hillsdale Hospital, where she oversees rural health and specialty clinics operations and leads community outreach initiatives. With a background in nursing and healthcare operations, Lindsey has been part of Hillsdale Hospital for 15 years, serving in leadership and operational roles for the past 5. She played a central role in developing and launching the hospital's new mobile health unit, which aims to reduce barriers to care and improve access to patients in rural communities. Lindsey is passionate about finding practical, patient-centered solutions that bring quality care closer to home. Right. And with that, I will be passing over the presentation to Lindsey.
Thank you, Rachel. Hi, everybody, and thanks for the opportunity to share what we've been working on at Hillsdale Hospital. This project, our mobile health clinic, has been something that we've wanted to do for a long time. The idea started before COVID as part of our goal to expand access in rural areas where patients face so many barriers to getting care. We tabled the idea during the pandemic, and then we did some rethinking afterwards and some creative partnership building, and now it's a reality. So it's been a project that's been in the works for a long time. So we're proud of it. Can you go to the next slide, please? All right, a little bit of background about Hillsdale Hospital. We're a 63-bed not-for-profit institution licensed by the Michigan Department of Health and accredited by ACHC. We have 44 acute care beds, 10 behavioral health beds, and 38 skilled nursing and long-term care beds. We also have labor and delivery services, emergency care, lab, radiology, a variety of outpatient clinics and specialty services, and we have a home health agency and a DME store as well. We serve a largely rural population, and because we're a small community hospital, we wear a lot of hats. So we do acute care, long-term care, and just about everything in between. Next slide. Our health system includes several family medicine clinics. So we have Reading, Hillsdale Medical Associates, which is also on Broad Street. There's 2 locations for that one. Hillsdale Health and Wellness, which is our mobile clinic is an extension of Hillsdale Health and Wellness. We have Three Meadows Family Medicine, and then we've got several specialty clinics. We're going to be opening up Hillsdale Spine Center in January as well. So all of this infrastructure with our primary care clinics and specialty clinics helps us support the mobile unit because it ties back to our network of services. When our patients need a follow-up, they already have like a home base that we can refer them to. Next slide. Just to give you a sense of our size, our emergency department sees about 19,000 visits a year. We have roughly 1,500 inpatient admissions and about 94,000 outpatient service encounters annually. So we're sort of a regional hub in our area. It just shows how much demand there is for accessible outpatient care options. Next slide. So a little bit about our population. Hillsdale County's population has declined slightly, about 1.9% since 2010. We're aging. Our senior population has grown significantly from about 16% to more than 21%. The entire county is designated as a health professional shortage area for primary care. And our poverty rate is higher than our state's poverty rate, so 21% compared to 13.5% statewide. Fewer providers, more aging adults, and more poverty are all factors that make access to care difficult for our patients. Next slide. So this is from our community health needs survey data, which has consistently shown that our residents struggle to find or get to a doctor. They've had long wait times and transportation barriers that come up again every survey cycle. So this happened in 2016, 2019, 2022, and then most recently last year in 2024. So we just knew that we had to do something different to be able to reach our patients. Next slide. Yeah, here you can see most of our patients wait for quite a while to get into a primary care appointment or a specialist, usually up to two to 3 weeks, especially for specialty. Next slide. So why a mobile clinic? Rural communities face higher health disparities. So heart disease prevalence is around 7% in rural areas compared with only 4% in urban areas. And then transportation, like I said, that's a huge factor for our patients. About 7% of rural residents miss appointments just because they can't get here. We see a lot of unnecessary ER use because people have nowhere else to go. They either don't have a primary care physician that they can access or they don't have transportation to get there. So lots of times they end up calling an ambulance and going to the emergency room. So finally, we realized that the local health department had purchased a mobile unit during COVID, and they were using it for WIC outreach, which they said had waned in recent years. So they were happy to partner with us on this project. Next slide. So our objectives for the mobile unit are to provide accessible primary and preventive care. We're hoping to see 800 to 1,000 adults across 2 rural locations. I think we could see 800 to 1,000 in the first year with the model that we're currently using right now. We'd like to achieve a 15% improvement in chronic disease metrics, like blood pressure control. We are doing this also for some goodwill in the community. We want to build some lasting partnerships with the community. And then we'll evaluate our success through patient satisfaction, reduced hospital visits, and cost savings, as well as the measurable health improvement. Next slide. The services that we're going to offer on our mobile unit that we are offering focuses on primary care. So it's going to be chronic disease management, lab work. We're also offering preventative screenings, cholesterol, cancer screenings, vaccinations. And then down the road, we're hoping to expand into other services. We've considered expanding into mental health, nutrition counseling, employee health. We're planning to assist people with Medicaid revalidation. That's something that's really important for our patient population in this area. So we've trained our MA and our NP that are on the mobile unit to assist people with Medicaid revalidation. And then telehealth consults with specialties are something else that we could consider offering. A lot of our patients don't have good cellular service or they don't have internet service. So some of the telehealth specialties that we offer, like neurology and oncology, is something that we could take to them. We've also considered going to schools to offer sports physicals, things like that. There's a large manufacturing facility in our area where we could go and do employee physicals. Lots of those people just don't have access to primary care. They don't have time off work, or maybe they only have one car. So we've thought about going to that manufacturing facility to offer services directly. So we're starting small, but we have the intention to build and expand. Next slide. So our staffing model is pretty lean, but this is what we thought we would need to start the mobile unit. We thought we would need one nurse practitioner and a medical assistant plus a driver, and then a physician for like periodic visits and oversight telehealth. What we've actually done is we have an NP and our MA who is also the driver. So the two of them are the only ones in the mobile unit, and they drive it, they do the setup, the takedown, all of those things. The MA is registering the patients, checking them in, checking them out, doing the vitals. And then our NP, she participates and does the encounter as well. So it's really just the two of them. We have our medical director for oversight. And the primary care medical director and the NP helped us decide like what equipment we would need, what services would be the most important to start with. So they were key to getting this off the ground too. Next slide. So some of the things that we went through in implementation, we had planned on securing funding and grants, which we didn't actually do for this project. We ended up getting this off the ground once we decided that it was definitely a go. This is something that we did starting beginning of August and then had our first clinic day and appointment on October 3rd. So this is brand new for us, and we kind of flew right through the implementation part as fast as we could. So we didn't end up doing any grants for this. And we used existing staff. We tried to use some of the equipment and supplies that we had. We happen to have an exam table and things like that from when we planned to do it before. So we were already partway there. Just had to pick those plans back up where we left them the last time. And we established partnerships with the health department. Like I said, we're using their mobile unit that they already had kind of outfitted for us. It had cabinetry in it. There's a refrigerator, things like that already there. And then we also reached out to some churches. We reached out to a church in Camden, which is one of the locations that we're going to, so that we could park in front of there, use their facilities for patients. And then same thing with the district library in Waldron. Once all of that was in place, we had to establish our mobile protocols. A lot of that was things like we had to do like the hazard emergency plan and some mobile policies as far as like lab collection, what our procedure is going to be for collecting them, dropping them back off at the end of the day. We got a centrifuge so we could spin them. It's kind of cool, plugs into the cigarette lighter adapter. And then we had to get federal approval from PCOS. So that really just entailed going and to the 855 and putting the mobile unit information in under Hillsdale Health and Wellness. And then we reached out to the compliance team who told us that we should treat it as an extension of Hillsdale Health and Wellness, like an exam room. So all of the policies and things that would apply to Hillsdale Health and Wellness apply to the mobile unit. Next slide. Okay, so once all of those things were in place, we went out and did a dry run because we wanted to make sure that everything was going to work smooth, and we wanted to see how long it was going to take our staff to get to all the places we needed to go, set everything up, make sure that our Wi-Fi was working, all those kinds of things. Marketing helped tremendously with our calendar, advertising. We did postcards out targeted to the communities that we're going to be located in. And we had to cover the graphics on the health department's mobile unit. So we got two enormous banners for the side of the mobile unit. And that was kind of challenging because we had initially thought that we'd be able to put up something magnetic, and it turns out it's fiberglass. So we ended up using bungee cords for the first couple weeks. Now we have some kind of fancy suction cups that hold the banner up. But had to plan for how to put all that together every time and take it down every time we leave. Pack up all of our stuff because we're still sharing this with the health department. They're using it. They're using it on Thursdays for WIC clinics, and then we're using it on Fridays. So we're loading and unloading each week. That dry run, that was important. It was a good learning experience. We went through the whole process and pretended we had a patient and everything. So it was a good idea. Next slide. Okay, our startup costs. So our startup costs were really reasonable because of the shared model with the health department. We had done a pro forma before COVID when we didn't have we didn't have anything started yet. The health department didn't have their mobile unit yet. We didn't have any partnerships with anybody. And our pro forma was in the six figures. We thought this was going to be very, very expensive. It turns out once they got this mobile unit with a grant that they obtained prior to COVID, it's been very cost efficient for us. So we estimate our first year startup cost will be about $25,000. So it's been very good for us to have that partnership with them. Next slide. So annual ongoing costs. This would be basically like if we were to run this mobile health unit every day as a mobile health unit, this is what we would think our cost would be. What we're actually doing by sharing with the health department is reducing those costs tremendously because we're only going out to the communities one day per week. So it's 20% of this cost really for us. And I think that that's going to help make it more financially viable because it is something that's it's been a little bit slow to get started as far as the community really adopting it as an option. So we're seeing more and more, but it was slow that first month. So next slide. Additional costs, yeah. So the total cost of operation of $250,000 annually, that's, like I said, that's what we would estimate the cost to be if we were going to go every day and in the mobile unit and had a full-time nurse practitioner, full-time staff. We'll end up at about 20% of that cost. Next slide. So these are some of the sources of funding. If somebody was looking to do a similar project or mobile unit, this is just some of the places that it would be worthwhile to look. We didn't end up getting any federal grants for our project, but I've seen some out there that would have applied. It's been a few months. There were some that were actually for partnerships with like more than one community agency that would have applied to this unit if we had done this earlier. Next slide. So measuring outcomes, this is really what our goals are to focus on. We want to have a reduction in the uncontrolled chronic conditions, and then we want to increase access to our community members and just reduce the missed opportunities to see them by breaking down some of those barriers that they face in getting to primary care. And then it's a lot of goodwill for our community to go out there and see them and be of service that way. And then we'll do annual audits and screenings. We'll track our encounters and survey results just to evaluate the program each year. Next slide. So this is kind of an initial launch checklist. This is some of the things that were on our checklist we got from the compliance team that they recommended that we go through. And then right now we're just waiting. We've done all these things. We're waiting for them to come and survey us. So that'll be happening in the next 3 months. We posted our schedule, put out lists. We had to put in the same kinds of lists and notices that we put in our exam rooms at Hillsdale Health and Wellness. All the equipment that we got, we had to have our biomed people at the hospital tag it, inspect it, test it, securing all of our items for travel. There's locking cabinets on the mobile unit, and then there's some totes that we take off and on the unit that we secure to the side with bungee cords while we're driving, because things they slide around everywhere if you don't. The power outage plan, it's got a generator, so for us that really, I don't think that'll really be an issue, but we do have some things that can plug in, like I said, to the AC adapter in the mobile unit, so that if the power goes out, we do still have like a cooler that we can run off the car battery. So some of that is just things that you would want to think about if you're doing this yourself. Next slide. Any questions?
All right, well, while we wait for people to think of some questions, I do have some.
Okay.
Oh, it looks like Joe may be unmuted. Did you have a question, Joe?
Yeah, do you guys do any scheduling of patients to go to your site there instead of doing a walk-in basis for those that you know, like were in the ED or readmit or admitted recently?
Yeah, we do. So basically what we've done, because it's part of Hillsdale Health and Wellness, patients who call Hillsdale Health and Wellness, or really any of our clinics, can schedule patient appointments on the mobile unit, but we put that phone number for Hillsdale Health and Wellness out there for the community so that they can call and make an appointment specifically for the mobile unit. But when our MAs notice that somebody lives in one of those communities that we're going to, they'll offer them an appointment for the mobile unit. And then we're also taking walk-ins. We do lab services there too. So if people have a follow-up lab that they need to get and they live in that area, we can refer them to the mobile unit.
Awesome. Thanks, Lindsay. It looks like Irene has a question.
Thank you. Great presentation, Lindsay. Appreciate this information. Thank you. I'm curious about the EHR that you use, and does that integrate then with your primary care or hospital? How does that communication and continuity of care kind of happen?
So the EHR that's on the mobile unit is Epic, and it's the same as what's in our clinics. So getting that set up specifically for the mobile unit, really, we just had to reach out. We're like a community connect partner with Parkview. So that's where our EHR comes from. And we reached out to them, and they had to do a separate service location, like a build for the mobile unit, to make it like specific to that. So it's really just a new location in Epic for us.
Thank you.
Awesome. We have a question in the chat from Corey. What are some of the feedback from the community and those utilizing the service?
So it's been pretty positive from people that have used it. They appreciate it. They appreciate not having to drive so far. We have a lot of Amish population in our areas that we're serving, so in Camden and Waldron. So they really appreciate it because, they're in their horse and buggy when they pull up and don't have to come all the way to Hillsdale. And so the word will spread through their community too. We did some outreach to the bishops, like the Amish bishops, and let them know that we're offering the mobile unit, where it's going to be and when. So that's something that we expect their communities are really appreciating. They're giving us great feedback on that. And then it's just nice for some of those people who are maybe elderly. They drive around in their own community, but they're really not comfortable going all the way to Hillsdale, or especially when winter comes, they're not comfortable going all the way to Hillsdale. They don't have the gas money and things like that to come this far multiple times a week. So they are really appreciating that.
Awesome. Thank you.
Mhm.
April has a question. How do you coordinate with primary care? Should the patient in the mobile unit have established care in one of your other clinics?
Yeah, so I mean, our primary care clinics, they do all have different providers, but we really try to be as cohesive as we can and kind of act as one, like one team. So if somebody who normally sees, Scott or Rihanna at Hillsdale Health and Wellness wants to have an appointment with Sherry on the mobile unit, that's totally fine. And she can see, all of the records, and she can see what they've done for that patient, communicate with that provider.
And then Wendy has a question. And Wendy, I might need you to unmute and clarify, but I'll read it first. If you only go to a certain place in community, how do people get to you?
Yeah, so way back when we first imagined this, we had thought about going directly to the patient's home
Hmm.
to do the care. But that actually wasn't feasible for a lot of reasons, which I think having the rural health designation, with that rule, you have to say exactly what address you're going to be at. Like, I'm going to be at 205 South Main Street from 9 to 3. It's that specific. So going to each person's house really wasn't an option because of that. And then also because of having to, like, close everything up, strap it back down to drive, would take forever. So um, we try to just go to the furthest locations from Hillsdale, from where we're at, that we still serve. We have patients there, and we're just really getting closer, and we're in town. So if people they just need a short ride, it feels like less of an ask for them to get a ride to the library in the same town where they live, or just not to have to come all the way to Hillsdale. We've cut about half an hour off of the drive. So
I
yeah.
think you just answered Kate's question. She asked, how do you determine which locations can be best utilized by the most amount of people? So,
Yeah. So really there's a few, and part of the reason that we chose Camden and Waldron, they are very, very rural. They have a lot of Amish population. They don't have any other primary care offices in them. Like, there's no other health clinic in that area, no other provider. Like, some of the small towns around here have a local provider office that either is or isn't a Hillsdale Hospital office, but these towns don't. There's others in our area, like Somerset, Litchfield. There's no provider there. So when we're expanding, those are the kinds of things that we would look for to choose our next location. And then since we've started this, we've actually had community members write and ask questions, like on our Facebook page. Hey, can you guys please come to Litchfield? So
yeah.
we might.
Yeah. It looks like we have a question from Lori. Do you currently partner your services with any community paramedicine services?
No, we haven't. It's really what we're doing. It's just our primary care service, and then referring and referring back to our specialty services, our home care, our DME, consults with our wound clinic, things like that. And then trying to get some ancillary services. So patients need x-ray, they need mammography, they need labs. We're referring for those things. Trying to set that up so that it's still like it's still a little bit of a transportation burden if they do have to come to the hospital for some of those things, but it's less if we're out there. We'll do as much as we can for them. People want labs and want vaccines, and we can take those things to them. It's just that fewer appointments that they have to go to for us. But we haven't done that. We are also working with DHHS. We became a community navigation partner with them so that we can help people who need revalidation for Medicaid or they need to qualify for Medicaid.
Thank you. It looks like our chat questions have kind of calmed down. So I'll go through some of mine. One is, were there any particular conditions that your site was focusing on for the use of the mobile health clinic? Or was it more only to address patients with overall access issues?
Well, it's not really like any specific condition, but there are certain conditions that we see frequently in primary care clinics, and those are the things that we wanted to make sure we could address in the mobile unit. So we wanted to make sure that we could do like testing for UTIs. We wanted to make sure that we could do the point of care A1C testing, things like that. And then the labs were really an important part of that. A lot of the patients that we're seeing haven't seen a provider in years. So we're just trying to get some baseline data on those folks that are new to us. But certain things, like if we have a patient that we know has a certain condition and we're going to need something, we'll prepare for it before we go out.
Awesome. How far in advance, like, do patients get scheduled for the mobile health clinic? Like, do you have a list for like weeks out, or is it?
Yeah, our schedule is open. Like right now, it's open through the month of November,
Okay.
and we can open it up further if we need to. But a couple weeks in each location is open to be scheduled.
All right. Any other questions? Okay. Well, if we are satisfied with questions, we're going to move on to our MVC updates. Thanks, Lindsey, so much for your presentation. It was really informative.
Thanks for having me.
All right, so upcoming work groups for MVC. Today was our Rural Health Workgroup. We have a post-discharge follow-up work group coming up on Thursday, November 20th. This one is going to be run by one of our MVC folks, Janice Stewart, who will be doing a little bit of follow-up from her patient journey presentation that she did earlier in the year. And then it'll be in collaboration with a couple folks from HBOM, one of our other CQIs. So that'll be a really interesting work group to attend if you can make it. And then in December, we have a pre-op testing work group and then our health and action work group on the 18th. And that'll be it for the year of 2025. We do have our 2026 engagement calendar up on the website. I will also be linking it in the email for you guys. That'll have all the dates for our upcoming work groups starting in January through the next year. We are looking for presenters, so if you have an interesting project that you think would be great to share with our MVC members, definitely send a presentation proposal in. We'll have a link for that as well for you in the email and also in the slides. And then we'd also love to schedule some site visits for 2026. I know in the first quarter it's winter, and in Michigan, nobody wants to drive in that. So we do offer virtual site visits that are really actually pretty fun and engaging. And we'll have the link for requesting a site visit in the email and in the slides for sites if you're interested. And that does, you do get P4P points for participating in that. And then you can also, for the presentation proposals, you can send in interest for presenting at one of our collaborative wide meetings as well, which will be in the spring and then in the fall, which I will have details on that as well for you guys. And that is it for today. Thank you everyone for attending. Thanks again to Lindsey, and I hope you all have a great rest of your day. Emily will put the link for the post-work group survey in the chat for you all. So we'll stay on for a bit to let you get that. It'll also be in the email that we send out later today. Thank you.